to provide more care. And a strong program, a strong, well-built program offering medication-assisted treatment for opiate use disorder is a wonderful way to attract the grant monies out there. They're always, the money keeps coming, and we need to be ready to catch it and have a program that we can say, look at this is what we're doing, please support us. Next slide, please. General guide to acronyms and terms, medication-assisted treatment, that's MAT. Some people say MAT. I say that occasionally. MAT doesn't mean much to most people, so we need to be willing to clarify that it means medication-assisted treatment or medications for addiction treatment, as some prefer. Some also prefer medication-assisted recovery, and also medications for opiate use disorder is what the UCLA teams use. So there's kind of a bunch of ways of talking about this one thing. But I think the most common term in our field when we're talking with each other is MAT. OUD means opiate use disorder. We're going to get a little deeper into what defines opiate use disorder. Stigma is the barrier to care communicated by language, judgmental attitude, and because of this judgment, a decrease in quality of care. And the word diversion is a word that we use often. It may not be familiar to everybody. It means trading, selling, stealing, sharing, buying illegal or prescribed controlled medications and substances. One example is Suboxone, the buprenorphine naloxone that is prescribed is also very available on the streets through diversion. For a while, when OxyContin was a very common opioid of choice, there was a river of diverted OxyContin out there that got people more deeply into addiction. So diversion is also going into your grandmother's medicine cabinet and helping oneself to Norco. So any time that it is a non-prescribed substance, or if it is not being taken as prescribed, we've walked into the world of misuse and diversion. And misuse replaces the word abuse, really important. The word abuse can be very pejorative, and we no longer use it. Taking more than prescribed, using non-prescribed opioids, including IV heroin. Next, please. Common terms, harm reduction is the defining features are the focus on the prevention of harm rather than on the prevention of drug use itself, and the focus on the people who continue to use drugs. So the focus is on the person rather than the drug use. Needle exchange, opioid replacement therapy, harm reduction is committed to the patient's right to care, no matter where they are in their opiate use and other substance use. So the harm reduction is common. That's what medicine is. We decrease harm, and it's a theory and an approach that has been developed in the treatment world and very important. Abstinence-directed substance use treatment, which is focused on abstinence from all drugs and alcohol, very common in all 12-step informed treatment facilities. The term clean and sober means complete abstinence, but does not, interestingly, include abstinence from tobacco or caffeine. Level of care, LOC, using American Society of Addiction Medicine criteria for assessing whole person needs and best level of care for stabilization. This is a crucial concept, a crucial assessment, and really important in understanding what is going to support this patient in their process of change and stabilization. Next, please. Opioid or opiates. So 5 years ago, this was a more interesting conversation because everybody was still saying opiate and the new word of opioid was being introduced. Now everybody pretty much says opioid. Opiate refers to natural or slightly modified components of opium, such as heroin. The term opioid was originally used for synthetic opiates, such as oxycodone. Opioid is now used for the entire class of drugs. So the opioid receptors, this is really interesting information, are distributed widely in the brain, in the spinal cord, on peripheral neurons, and the digestive tract. So one of these symptoms, the side effects of opioid use is constipation, and one of the withdrawal symptoms is diarrhea. So you can see how the digestive tract is tied to opioid use, and that's where the receptors are. Very interesting. Also, how it relieves some, we feel anxiety in our abdomens, and also, so often opioid will relieve a sense of anxiety in that part of our body. The emotions are in the body. What do we mean when we say full agonist opioid? Full agonist opioids activate the opioid receptors in the brain, fully resulting in the full opioid effect. A full agonist goes to the receptors and activates the effect. Next, please. Some common full agonist opioids: hydrocodone, morphine, also MS-Contin, hydromorphone, Dilaudid, which has been a very popular diverted drug, methadone, tramadol, fentanyl, and heroin. These opioids have a varying length of half-life. A shorter acting drug, such as heroin, can drive the severity of the opiate use disorder. So if you look at this list of common full agonist opioids, you can see that methadone, we know, is a very long-acting opioid. I think it's 34-hour half-life. And heroin is a 30-minute half-life. So frequency of use really can drive behavior, which kind of points to why methadone was introduced as a treatment for the shorter acting opioid use. So there we have it. Methadone is a long-acting full agonist opioid, which has been the primary treatment as opioid replacement for opioid use disorder. This has been around for many, many decades. Methadone clinics are highly regulated and require daily dosing in the initial stage of treatment. Methadone is one of the treatments for opiate use disorder and can be an excellent level of care. When we were talking about level of care a minute ago, so these are the ways that we consider the needs and the preferences of our patients. Next, please. Buprenorphine and methadone. So somebody asked me, why would a patient choose or be referred to methadone for treatment of their opiate use disorder? So methadone is considered a higher level of care because of the required daily dosing, frequent urine drug screens, and breathalyzing for alcohol, and the slow approach to take homes at the highly regulated methadone clinics, which we call NTPs. So you can see that the patient, when they start methadone treatment, they will be required to go every day, which is not the case with buprenorphine programs in primary care. If a patient continues to struggle with MAT program adherence, including taking buprenorphine as prescribed, a referral to NTP programs for more frequent dosing of buprenorphine or methadone can be indicated. A patient might choose to switch to methadone at the time of this referral Some patients report better management of cravings with methadone. This is crucial. And it's critical that we have this choice to offer our patients. Full agonist also continues to numb emotional and psychological pain, which some patients with severe trauma symptoms prefer. So this is a point I really want to make. And we'll talk a little bit about trauma and opioids, but a full agonist, a methadone can sometimes relieve some of the other emotional and psychological pain for patients with severe trauma. So they may be directed to methadone treatment or prefer and choose it for that reason. For more information, this is a good link. So if you want to know more about methadone and buprenorphine, check that one out. Next, please. Opioid dependence plus behaviors equals opioid use disorder. Outside of the world of addiction treatment and opiate use disorder treatment, there's often a misunderstanding. Opioid dependence is physiologic, which includes tolerance, which tolerance causes a need to increase quantity to sustain the effect. So over time, there's going to be a inclination to feel like you need more to manage the pain, and withdrawal symptoms when opioid is stopped. So this is where we need to think about babies who are born with neonatal abstinence syndrome, babies who are born. They are born with dependence. It's important that we do not identify our babies as being born addicted. Already there is stigma being directed at that brand new human being. They're born dependent. And also there are many, 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 many chronic pain patients who have been prescribed opioid for pain management, who take as prescribed, and they often get caught up in being identified as being addicted. They have dependence. So take care of our patients by using the right language with the right understanding. Addictive behaviors, when added to dependence, involve misuse, such as taking more than prescribed or continued compulsive use in the face of increasing consequences to health and wellness. Diversion and relapse driven by cravings and triggers. So this is really the basic understanding of the opiate use disorder. It's behaviors, often very poor choices made to relieve craving and withdrawal. So if you get anything out of this slide set, this is important. Next, please. Why is there a focus on trauma care in medication-assisted treatment? So as we talked about earlier, full agonist, when given to treat physical pain, is effective in that it changes the perception of all pain. An opioid also numbs emotional and psychological pain. The numbing characteristics can turn off the symptoms of trauma. The relief which comes from opioid use and misuse is often the beginning of addiction. So this is where we got into trouble with pain meds for pain, and the person experiencing relief for lots of other painful symptoms, especially trauma. When a patient seeks help for opiate use disorder, we must help them discover and heal the root cause, which is often childhood and or adult trauma. This is especially true in our Native communities, where the impact of historical trauma is being understood and addressed, and this is really tied to the higher levels of opiate misuse and overdose in our Native communities. Very important link. Many MAT programs screen for childhood trauma with the Adverse Childhood Experiences screening. The ACE scores in MAT programs are often very high. So adverse childhood experiences is 10 questions that evaluate for physical, sexual, emotional abuse, neglect, and household and family dysfunction. So very tightly connected. Next, please. The return of the felt experience. A lot of people do not know this about buprenorphine, but it's important that we do. When our patients discontinue the misuse of full agonist opioids and have started on buprenorphine, which is a partial agonist, there will be a return of emotions and sensations. Return of emotions and sensations is a crucial thing for us to understand. It has been described as an emotional thawing out or tingling to life. This is important to remember in the context of sensitivity to trauma and on other untreated behavioral health diagnoses. So if we understand that our patients with opiate use disorder are self-treating, I don't like the word self-medicating, but they're self-treating with, let's say, IV heroin, it's important to understand that when we stabilize them on buprenorphine, there's going to be a new experience where they are actually feeling again, and all those feelings may not be good. The return of painful emotions and sensations can trigger relapse. Behavioral health members of the MAT team must be ready to respond with more care and support. We also need to educate. Recovery must include educating our patients and offering the early and recovery tools for self-regulation. Crucial in our care of stabilizing our patients who've been suffering with opiate use disorder is understanding that they are going to be able to feel, they will be feeling more in the world of emotions and sensations when they are started on Suboxone buprenorphine. Next, please. Addiction or substance use disorder. So we often hear addiction and we hear substance use, and we know that we don't use the term substance abuse anymore. So addiction is a chronic progressive relapsing disease. We use this term in medicine. For now, it will probably change. American Society of Addiction Medicine is a medical society. I am an addictions RN, and there are providers, doctors that are called addictionologists. You walk across the hall into behavioral health, and then you have substance use disorder, which is how it's identified in the behavioral health DSM-5. And substance use is, addiction is a chronic progressive relapsing disease, and substance use disorder is measured on a continuum of mild to moderate to severe. So we use opiate use disorder, severe, stimulant use disorder, moderate alcohol use disorder. So we identify on that continuum, and this is a really important way of measuring severity, which will be part of the way that we identify treatment plans and best optimal levels of care for our patients. The term polysubstance use is, even though we use it, actually in substance use disorder and DSM-5, it is not utilized. We are very specific about the type of use disorder that we're looking at with the patient. So in one world, we're talking about addiction, in the other, we're talking about substance use disorder. And I think that substance use disorder right now is winning out. I know that when I started in working in addictions, we called it chemical dependency. That was the term we used. Okay, next, please. Discover simple ways to change language, teach trauma sensitivity and empathy. This is the work of every person in our clinic, is to restore dignity to our patients. There's a nice quote: when a flower doesn't bloom, you fix the environment in which it grows, not the flower. Next, please. So stigma in our thinking, attitude, and our language. Stigma has been identified as the #1 barrier to ending the opiate epidemic. It is prevalent and it is pernicious and it is built into our systems. But here we're going to talk about our clinic, our staff, and our patients. So stigma is shaped by our thinking, a bias and perception that substance users are bad and immoral, rather than ill with a chronic conditioning requiring care and treatment. Often there's more than one chronic condition, such as mental health disorders, which also require care. So if we see our patients as having an illness that needs treatment rather than that they are bad, we will begin to shift the whole process of care. Stigma is communicated by tone. It can be really subtle, interpersonal attitude and body language. And stigma is communicated by words. Stigma becomes internalized by a person seeking help. Person views themselves as bad, as dirty, as weak, which fuels the shame of stigma. Our job is to change this. Next, please. Stigmatizing language we no longer use. There's quite a few, but I'll give you a few examples. Abuse, as in substance abuse, is no longer part of the medical lexicon, was identified as the only diagnosis which had the word abuse. We use misuse or use. We can say opioid users or prescription pain misuse, pill misuse. I have to point out that SAMHSA, which is a Substance Abuse Mental Health Services, is still using that term. I don't know if they'll change, but as long as they keep sending us support and funding for our work, we'll let them call themselves SAMHSA for a while. Addict is a word that we never use anymore, believe it or not. Rather, we use person with substance use disorder, people who inject drugs, or opioid users. Still used in the 12-step culture as a part of the recovery process. So we're not going to go into NA and change their culture and their approach. When someone walks into a 12-step NA meeting and says, I'm Katie, I am an addict, it is a way of saying, I have this problem and I am willing and ready to make changes to work on this. But in the world of medicine, in the world of treatment and behavioral health, addict is a label that is so pejorative and hurtful that we really have to stop using it. No need to use it. People with addictions is people with substance use disorder. There are ways of not saying addict. Drug seeking, which is also a favorite term in medical settings, especially emergency departments, can be reframed as relief seeking, focus on the person rather than the behavior. So if someone comes in and they're in withdrawal and they are hoping that the doctor will prescribe maybe some Vicodin, often they are defined between the staff as drug seeking, med seeking, to reframe as this person is seeking relief is going to change how we see the person and will probably give us an opportunity to offer some real care. Nodding out is a street term that is used to describe sedation caused by too many opioids or combining opioids with other sedating drugs. Often you'll hear this in treatment, so-and-so is on Suboxone and we're noticing that they're nodding out in group is a very common thing that we hear, or even somebody at the front desk saying, so-and-so is nodding out. So we don't really know why that person is sedated. So the assumption that they are nodding out is both incorrect and pejorative. Next, please. Stigma is a secondary injury. So I love this picture, this image that we are user friendly, which means that we bring our patients in who have use disorders, and we take care of them with really a welcoming and respectful attitude. So stigma is a secondary injury of substance use and can require treatment. Next, please. So if we think about, imagine someone who is, let's imagine someone who has alcohol use disorder, who has struggled with sobriety, struggled with their use disorder, and after 20, let's say they've been working on getting sober for 20 years, 2 decades. And we understand that the stigma that they have been touched by in the medical world can be hit and miss. You may have a respectful provider one day and one that treats the person with alcohol use disorder with disdain. So when you think about how this stigma has impacted that human being, we will really work very hard to change this. So I identify it as an additional injury. We begin with the acknowledgement of the injury caused by stigma. I've met with many patients. We've had very honest conversations. Symptoms can be fear of emergency departments, distrust of medical providers, and feelings of shame and dishonesty. And one of the driving factors is that just about all of us have substance use in our own families or in our own world of friends. And we feel frustrated and angry and disappointed and afraid. So that can also drive stigma. If not treated, the person internalizes the shame and low self-worth caused by stigma. So we have to rebuild. So a treatment for the stigma injury is the language of dignity, empathy and compassion, kindness, respect, and listening. And really understanding the impact of stigma on a person. I've had so many patients that have just declined going to much needed ER for care because of the stigma they've endured. This is a very real thing. Next, please. Urine drug screens. These are our labs that we use frequently. In medicine, we do not refer to lab results. Any lab results is clean or dirty. We use medical language at all times to support the dignity of our patients. This is one of the most common stigmatizing behaviors in our clinics. There's been a great deal of progress being made, but I just heard a provider use the term dirty a couple of days ago. So we're not fully there yet. We would never refer just the A1C results of somebody who is working on their diabetes as dirty. So bear in mind that we are talking about a lab. And if we're at the front desk, better to say lab than a urine drug screen as a way of supporting the dignity. It is a lab. When we talk about the results, we say positive or negative, consistent or inconsistent. We're also going to want to identify what it's positive or negative for. If it's positive for buprenorphine, that's something that we want to see. If it's positive for methamphetamines, we're going to be concerned. So not just saying it's a positive urine drug screen, you need to specify what on the panel was positive or negative. Next, please. Human suffering. This is what, I love this Dr. Corey Waller's description of the intensity of craving. This is what we're dealing with. This is what is really one of the things that is driving the opioid epidemic. We need three things to survive besides oxygen: food, water, and dopamine. If you deprive study subjects of water for 3 days and put them in a functional MRI and place water on their lips, the relative size of the craving is like a baseball. So water is like a baseball. Do the same with food, and it is like a basketball. Then take someone with an addiction to opioids up to 1 year after their last use, and talk about OxyContin while they are in a functional MRI, and the relative size of that craving is the size of a baseball field. Next, please. So there it is: water, baseball, food, basketball, baseball field, the intensity of cravings up to 1 year when you hear about OxyContin. This is an important fact that we need to understand. Next, please. The other aspect is we have craving and we have opioid withdrawal. So these are the primary symptoms of opiate withdrawal. This is what we measure on the clinical opiate withdrawal scale when patients are getting ready to start buprenorphine. We have what they often describe as a severe case of the flu: elevated heart rate, pupil dilation, hot and cold sweats, intense overall body aches, especially in the back and legs. You've heard the term kicking. Often there's just unbearable restless leg syndrome in the withdrawal experience: runny nose, teary eyes, intense intestinal distress, severe anxiety and agitation, severe restlessness, tremors, yawning, and goose flesh. So when we think of our people and the kind of suffering that they endure with intense cravings and intense opiate withdrawal, it will give us a better understanding of how we can provide care and support. Next, please. Human suffering, the losses, the overdose deaths, about 114 every day. We're making some progress. There are millions of orphan children. Grandparents are now raising families. They're called kinship families now. They're so common. Babies born with opioid dependence. You'll notice I didn't say born with, babies are not addicts, or born with addiction. Children are in foster care. All of our agencies are overwhelmed: law enforcement, CPS, emergency services, heartbroken families and communities. Just about every single one of us now knows about or has someone close to us that has died from an overdose. Incarceration, felonies. Our young folks have felonies, and when they get back on track, this is difficult for them to build careers and find work. Really impactful. The medical challenges are Hep C, HIV, endocarditis, abscesses, cellulitis, also because of the stigma. These severe medical challenges are often not taken care of because patients don't want to go get help. Next, please. Oh, help. I love this image of the cry for help. Next. The solution is access to care. Addiction treatment starts here. To increase access to care, we open doors to treating opiate use disorder, develop a medication-assisted treatment program, community outreach, education. The education piece really needs to continue. That's what I'm doing right now. No wrong door, have an effective referral system, and keep barriers to a minimum. Next. The solution is medications of MAT. So we've talked a little bit about buprenorphine. Just real briefly, it is a partial agonist opioid. which means that it attaches to the receptors, but it's not fully activate. It has a high affinity for the receptors, low activating, long acting. So we're going to have stability just from that one long acting, 37-hour half-life. Relieves craving, relieves withdrawal, and if they're on the right dose, there's no euphoria. So it normalizes the brain very quickly. Wish I had buprenorphine for all the other substance use disorders. Combined with naloxone as a brand name Suboxone, and it's taken through the skin, sublingually or transdermal, so that skin under the tongue, which we call sublingual dosing. So it comes in through the skin. We have Butrans patches. Also subcutaneous injectable, it's getting used more. Sublocade, which is a monthly buprenorphine injection, and implants, which are not that utilized in our world. Naloxone is Narcan, opioid antagonist. It is an opioid overdose reversal treatment. This is what first responders are using. We've worked very hard to normalize Narcan. We would like to have Narcan in every household and in every purse. And there's a constant and very big push from the state of California to get the Narcan out there. Naltrexone is a monthly injection, long-acting, Vivitrol, blocks effects, it blocks opioids. Minimal, think about the cravings, the baseball field, there's minimal relief of opioid cravings, but effectively saves lives. So if you have someone who cannot fully participate in buprenorphine or methadone care, this may be the best approach. This medication is useful in treating opiate use with co-occurring alcohol use disorder because naltrexone significantly decreases cravings for alcohol. So it's in our toolkit. Next, please. So here's the pictures. Narcan, there's a Narcan, the nasal spray. That's the one that is getting widely distributed. There's what Suboxone looks like. The sublingual dosing, there's the Sublocade, which is the injectable, and there is the Vivitrol. So just an image for you all. Next, please. Solution is recovery and wellness, whole person care, case management for social services. So in the Native communities, the linking of our MAT patients to cultural and traditional care and connection with Native recovery. There's Telewell has a 2-hour every Friday afternoon Red Road series run by Albert Hittman and Bo Medicine Crow. Highly recommend it for our Native patients to have access to Native recovery. The White Bison movement is very supportive of MAT. Some of our clinics have Red Road talking circles as part of their care. This is an essential piece for our Native clinics to not just treat with medication, but treat with the medicine of culture and tradition. That's not my work, but my work is to support that and to make sure it happens. So whole person care involves connecting with culture first and foremost in our Native clinics. Also, there's going to be case management for social services, behavioral health, medical needs. That's whole person care. Recovery support, getting that patient into the right level of care, and to partner with our patients. We tend to be very paternalistic in medicine and even more paternalistic in the field of recovery treatment. where we tell everybody what they need to do rather than develop a partnership, a trusting, respectful partnership to help our patients return to healthy autonomy, return to values, understanding that the sensitivity of most people with substance use disorder, when they're at their best, they are wounded healers, they help others. Our field is just full of people who have found the way to sobriety themselves through their own lived experience and the creativity. So remember that you're not just treating somebody with a substance use disorder, but when they are fully bloomed as themselves, they will have many gifts to bring to the world. And so we need our people in recovery. We need our healers and artists. Life directions, getting our patients back on track with school, job training, getting them back into, so many of our patients are in their 20s and 30s and they need a lot of support. They need to learn how to get a job and fill out job applications, etc. And the essence of recovery is restored relationships, including one's relationship, their spiritual life, their family life, their community. And this is also really crucial in the Native community, is restoration of all relationships. Excuse me. Next, please. So I'm going to let you read this because I'm losing my voice. So how do you get into how do you change clinic culture? Clinic culture means training all the departments and all staff meetings. So arrange to meet with the team members. So arrange to send the team members to department meetings to educate about MAT and stigma, discuss how the MAT program will impact the workflow, for example, like medical records and billing. They need to understand, answer questions, reduce stigma, and develop FAQs about MAT and handouts on non-stigmatizing language. Next, please. So this is a general pathway of care. Our patients come in, we focus on stabilization with medication, monitoring, and recovery tools, screening and referral, assessment, begin with getting the patient safe and comfortable. So if someone walks in and they're in withdrawal, we do not meet them with a bunch of paperwork. We make sure that they get seen as quickly as possible. We want them walking out of our clinic with the possibility that they will never use again, which is always a possibility, not very frequently, but let's stabilize medically first. Start buprenorphine, right dose of medication, hand off to behavioral health and case management and the SUD team, a treatment agreement with a treatment plan, education, and support. Next, please. So here's some links to that might be helpful. SBIRT training is a really good thing. More from Dr. Corey Waller, motivational interviewing, core competencies. And we are actually having the MAT Nurses Weekly Forum. We have 2 more sessions, so if you're interested, send me an email. And how are we doing with time? So we have some time, and for questions, if you have them. I still have my voice, but I really want to take a minute to emphasize once again the value of white bison training, developing Red Road talking circles, and working with our telewhale Native Traditions and Recovery Team, Albert Tittman and Bo Medicine Crow. They're as available as I am through Telewell. And the integration of MAT into our Native communities should not happen without emphasis on culture and identity and recovery. Anyone have a question or anything to add, please? Oh, next one. So there's something now called MAT-S, substance use counselors can now receive additional certification where they're now identified as MAT specialists. Project ECHO, we meets every fourth Monday. We have Tribal ECHO, which is the third Tuesday. We had it yesterday. We had really a great presentation by Dr. Dan Dickerson, and Dr. Willis presented a case from the Riverside San Bernardino community. And then there's lots of videos. So there's tons of information on these last two slides that you can connect with. And that's it. Thank you, everybody, for your time. Any questions? Oh, yeah, this is available. Absolutely. We post these on our Telewell site, John. Thank you. All righty, everybody. Thanks for your time. You know where to find me. We're all in. Thank you. Is a really excellent question from Linda. Basically, the question is, are we enabling opioid use by having Narcan in all homes? I think that's what you're asking, where patients have been known to, yeah, Linda, I get what you mean. It's a form of enabling in some people's minds that you have Narcan out there, but you got to measure the risks and benefits. Yeah, you know, some docs say I don't want to prescribe Narcan because they hear about patients having something called a Narcan party, which actually sounds like oxymoron, where they have Narcan set out and they use it, and they use it as part of their using, so that they will save each other if there's an overdose. I think the answer is pretty obvious, that the saving a life kind of outweighs the other behavior, even though we do not want to encourage it. We don't want anybody dying of an overdose. So Narcan may be used in a way that we feel is inappropriate, but we do want Narcan available to everybody. We have lives to save. So M. Barnes says, so due to us not having a MAT program, I'm having to screen PM patients and send them to behavioral health for an ASAM assessment. Pain management, okay. I just needed to scroll patient, but in that I'm having a hard time bringing what is the best way for a provider to bring up the subject, right? I fully understand your question. And we are about to start working more directly with your clinic to help you with the sorting, because not all pain management patients also have opiate use disorder. Some of them do, and then around that continuum of mild to moderate severe. And then there are some that are fully in severe opiate use disorder, and they're obtaining medications that are contributing to their continued problem without a clear assessment from the team and from the providers. Any others? Well, I gotta go. I have a 1 o'clock appointment. Thank you, everybody.
Thank you very much, Katie. Thanks to everyone for attending.
Thanks, Jeff. Bye.